All right, welcome back to the last session of today. Thank you, Dr. Susilo, and the music, very powerful. I think Dr. Holzki enjoys it as much as we do here. Hi, Andre. All right, so for the next sessions, we will talk about airway management. I think this is the first airway session management, airway sessions in Indoanesthesia. It's been almost 3 weeks now, and we haven't had any discussions about airway. And so for today, we have 4 prominent speakers in the field of airway, and the discussions will be led by Dr. Andi Wijaya. And I would like to thank Advanced Medicare Corpora for sponsoring this event. For the first speaker, it will be Professor Friedrich Puhringer from Germany. He is the professor and the chairman of the Department of Anesthesiology, Intensive Care Medicine, Emergency Medicine, Pain Therapy, and Palliative Care in the University of Tübingen, Germany. So for Professor Friedrich, I think the time is yours.
It is a great pleasure for me to talk about the importance of video laryngoscopy in times of COVID-19. My hospital is the Klinikum am Steinenberg in Reutlingen, which is an academic hospital of the University of Tübingen. And I'm a professor and chairman at the Department of Anesthesiology, Intensive Care, Emergency Medicine, Pain Therapy, and Palliative Care. It contains of 66 anesthetists. We are serving 12 operation rooms, and we are doing around 12,500 surgeries a year. I'm also medical director for more than 10 years now for the whole hospital company, and my main research interest is in patient safety. Let's come back to the topic of this presentation, the importance of video laryngoscopy. What's the idea behind? The idea behind is to widen the visibility of direct laryngoscopy. Direct laryngoscopy has a visibility of only around 10 to 15%, so a very, very narrow view to get to see the laryngeal structures. Whereas in video laryngoscopy, the chip is at the tip of the blade, and therefore there is an increased visibility, which gets up to around 60 to 80%. What about the impact of video laryngoscopy in 2020? And almost in every algorithm of national or international societies, like from the US, from Great Britain, from Germany, France, Canada, India, Italy, and South Africa, and even more countries, video laryngoscopy has already a core place in the case of an unpredicted difficult airway situation. In some countries, it's already called Plan A. At least it is Plan B in an unexpected difficult airway. And I do think we should implement video laryngoscopy as Plan A in modern anesthesia in our days now. When we look at the various models of video laryngoscopes which are available on the market, it's pretty hard to figure out which one to use. And therefore, we need to have some guidelines how and when to implement a video laryngoscope in our daily clinical practice. When we have a look at the literature, there are some very important papers who give us some guidance in terms of which and how to use video laryngoscopes or any airway devices which are getting to the market in our days. First of all, there was the ADAPT concept from the Difficult Airway Society of Great Britain. And the ADAPT concept tells us that we should at least get an evidence of 3B before new devices are taken into clinical practice. Practice guidelines for management of difficult airway, and a very interesting paper at the bottom, evidence for benefit versus novelty in new intubating equipment. And Baring wrote very, very nicely that such devices should be available in all settings where tracheal intubation is performed. Experiences and competences are critical for the successful use in the clinical setting. This means that we should use and train these equipments on a daily clinical pace, because otherwise we will not be successful in an emergency situation. When we look at video laryngoscopy, an important question is, what is the efficacy? Is it better than direct laryngoscopy? We do know that the visibility is getting better. We have a wider angle of view. But again, is the success rate higher? And this is what is pretty important to evaluate the efficacy of video laryngoscopy. Several studies have been performed, and I would just like to point out a few of them showing the benefits of video laryngoscopy. This was a very nice comparing study where 300 patients have been first intubated or laryngoscopy has done with the conventional technique, like with direct laryngoscopy. And secondly, the same patient has been got laryngoscopy with a video assistance system. And in both ways, the Cornerstone score has been evaluated. And when we look at the results of the visibility of the laryngeal structures, we can clearly see that the gray bars are the results seen when we did conventional laryngoscopy. So there were several 2B and 3 and even 4 Cornerstone grades. But when the same patients got video laryngoscopy, these high grades of Cornerstone scores, they were just shifted to low grades. That means we had a higher incidence of Cornerstone grade 1 and grade 2, because all those higher grades from direct laryngoscopy were shifted to lower grades. So visibility dramatically was improved. And this is a clear sign that due to the wider angle of visibility, laryngoscopy was much, much easier when using video laryngoscopy. In another study done by Meininger, also in Germany, they compared direct versus indirect laryngoscopy with a video laryngoscope in beginners. So beginners did the laryngoscopy either the conventional way or with video laryngoscopy. And again, there was a clear shift in those scores under video laryngoscopy towards lower Cornerstone grades. The good glottic view was achievable in 84% of the patients versus 58% in direct laryngoscopy in the same patients. So a dramatic shift towards better glottic view. Results were even more impressive when professional healthcare providers, old, very experienced anesthetists, performed the same setup. So each patient was laryngoscoped with the direct laryngoscopy and with video laryngoscopy. And again, the incidences of low Cornerstone grades like 1 and 2, which we clarify and we identify as good glottic view, dramatically increased. So good glottic views were achievable in 88% of the patients versus 25% in direct laryngoscopy only. And if we consider 2B as well, Cornerstone score as acceptable, the difference was between 95% acceptable view in video laryngoscopy compared to 62% in direct laryngoscopy only. So all the scores and all the evaluations and studies clearly showed a dramatic increase in better view, better laryngoscopical results when video laryngoscopy was performed. I would like to go back to the ADAPT concept, just to talk a little bit about evidence and what it means. ADAPT concept from the Difficult Airway Society promoted that at least 3 B level of evidence should be available before new devices in airway management are introduced in daily clinical practice. This means single case control studies or historical control studies at the minimum should be achieved. So we should have a look which evidence one or another video laryngoscope achieves, which device reaches the 3B level. What we can see is that for Macintosh blades, only the CMAX system has a level of 2B. No matter if we look at normal airway situations or if we look at difficult airway situations. The advanced scope, the McGrath scope, the glide scope does not have any evidence in Mac-bladed video laryngoscope. If we look at hyperangulated blades, non-Mac blades, video laryngoscopes, we can see that several scopes, like the glide scope, like the McGrath, and as well the CMAC D-blade, show high level of evidence. 2B for glide scope in normal airways, in difficult airways. For CMAC, also 2B for both airways, for normal and for difficult airways. And for the McGrath, 2C for normal airways and 3B for difficult airways. So at least 3 types. But if we combine hyperangulated blades and Mac blades, the only system that really achieves for both blade types a sufficient level of evidence is the CMAX system by Storz. Well, which device did we choose for our institution? And we chose, based on the evidence facts I just showed you a second ago, that we are using the CMAX system from Storz because it's a modular system. One monitor fits all. You can plug in video laryngoscopes, you can plug in rigid scope, the Bonfils, and even you can plug in classic fibroscopes by using a camera, or you can use the new chip bronchoscopes, the video endoscopes, the 5s. So one tiny little monitor combines all the valuable airway tools which we can use in the intensive care or in the operating room. And it's small, it's easy to be carried around, and we can use it no matter in an operation room or an induction area or on the intensive care. Well, when we look at the devices for unpredicted difficult airways, we need tools. We need tools we can work with on a daily routine, which are easy to use, and we can implement it so everybody is familiar with it. There is no learning curve in emergencies, no difference in the normal procedures. It is the ability to observe the procedure from the assistants or from the teacher. And it has a broad field of application, so we can use it in a wide range of patients. And for all these reasons, we have chosen the CMAX system. Once again, I would like to show the similarity of the CMAC Macintosh blade style compared with the dialect laryngoscopy, the old style. And you see that the form of the blade is just identical. But again, the visibility, the angle of the view is just much wider with the video laryngoscope, and this is the big advantage. If we look at the hyperangulated blades, there is different shapes, but again, you can look around the corner because with the blade, you are looking straight, but with the D blade, you are looking in a very, very upwards direction, which means you're looking when you have a very anterior larynx just upside, again in the opposite direction. It improves the view around the corner. And for pediatric cases, the Miller blade as well is established as one of the blades for pediatric cases in the CMAX system. So the CMAX system provides Miller plates, Macintosh plates, and hyperangulated plates. And they're easy to plug in, always with the same monitor. There's no need for changing anything, just changing the different plate types, whatever you want. To give you an impression how our induction room in Reutlingen looks like. And you see, there is the CMAC monitor fixed on the wall. So in every induction area, we implemented a CMAC monitor, and we are using in every room routinely a size 3 and a size 4 blade. This is what we prepare before the operation starts. We are also having airway trolleys. And on the right picture, you can see that we are the old style big trolley, which is hard to move around. But on the left side of the right picture, you see our small airway trolley, which I already explained previously, contains of all the equipment we are needing. Blades, the Bonfils, the flexible scope, the camera, an additional battery set for the Bonfils, and an entry into intubation catheter. The whole airway equipment is on just that tiny little trolley. And this is, I think, what is of utmost importance, that we really provide a one-fits-all system for an emergency situation in our operation room. We established in our department a specific training program for our residents. So the first step is that they have to learn face mask and laryngeal mask airways. This is what they train when they start residency in our department for the first weeks. After that, they get trained on CMAC, on Bonfils and flexible scopes on the mannequin. So the use of all these technical devices is trained and taught initially on the mannequin first. Then in the operation room, we perform direct laryngoscopy, conventional laryngoscopy using the CMAC system. But the resident initially is not allowed to watch the monitor. Teacher, the senior lecturer, is watching the monitor, so we can observe how the resident intubates. And we can see if there is any troubles coming up or if they are doing it in a perfect way. Once people achieve the skill of direct laryngoscopy, they start using the CMAC by watching the monitor. The next step is the teaching of the intubation using a rigid fibroscope, the Bonfils, on the monitor, and to train the hand-eye coordination, because you are using the Bonfils with your right hand, and the coordination to guide it into the laryngeal area is somehow tricky. Again, training initially on the mannequin, secondly on the patients. And once people achieved all these basic skills of airway management, we start teaching the flexible fiber optic intubation, or in the oral way, but in asleep patients after the induction. So we are doing this in one operation room on a regular basis every day. So this is the oral flexible intubation in asleep patients. And once people are really used to the use of flexible fibroscopes, people are starting the awake nasal fiber optic intubation. So it's a very, very clear curriculum and training program for our residents, because we want to teach them gentle but very strict to perform it in a nice and proper way. There are some images about our trainings on the mannequin, and even the cricothyroidotomy is trained on the mannequin. We are using porcine larynges, which we get from one of our butchers regularly, so that all the skills like intubation with the video laryngoscope, the Bonfils, the flexible scope, and the cricothyroidotomy are trained continuously on the mannequin and in specific airway management courses. Let's come back to the topic of this presentation, direct or video laryngoscopy in COVID-19 times. This is a direct laryngoscopy attempt in a COVID-19 patient. Would you like to have it done like this? You see the narrow distance between the anesthetist and the mouth of the patient. And we do know that during intubation, the highest concentrations of aerosols are flying around. This is not a good way to intubate patient in COVID-19 times. This is why we do not perform direct laryngoscopy in COVID-19 times at all. We do not even perform direct laryngoscopy in normal times. It's all about the safety of the coworkers. Medical personnel is so relevant in these days, so we cannot afford losing some of them. And this is why direct laryngoscopy in COVID-19 times is obsolete. This is how safety occurs. If there is a video laryngoscopical view of the larynx and there is a huge distance between the anesthetist and the patient, so that there is no contamination of aerosols. Yeah? We do know from very recent studies that this is the best way to not to get affected by aerosols. Much better than putting some plastic boxes around the head of a patient, because this doesn't prevent at all, because you have to go into these boxes and the concentration of the aerosols in the boxes are so high that your hands get dramatically contaminated. So no plastic boxes, but video laryngoscopy and an acceptable distance between the anesthetist and the patient. And I would like to show you an interesting thing we implemented a couple of years ago in my department. We implemented emergency buttons in every operation room. So these emergency buttons, as you can see, should be are pressed once colleagues run in any trouble in the operation room, but mainly when they run into airway trouble. And once this button is pressed, a telephone, which is actually covered by one of my deputy directors, and the head nurse, the anesthesia head nurse. And then these two people are rushing to the operation room where the button is pressed. So every operation room has a number, and this comes up on the mobile telephone here. Why do I show this? Because this is the call for unexpected difficult airways. And before we started using the CMAX system, usually 3 to 4 times a week, this button was pressed. We had around an incidence of 3.5% of difficult airways in my department. In 2012, we implemented in all operation rooms video laryngoscopy using the CMAX system. And now the incidence is around 1 emergency call per month, per 2 months. And the incidence of difficult airways dramatically dropped to 0.15%. So this is a huge increase in patient safety. This is a huge reduction of problems. And this is really the big benefit, that when you are implementing video laryngoscopy in your daily clinical practice, the incidence for unexpected difficult airways is dramatically going down. Just to summarize our philosophy, only techniques practiced every day provide successful use in emergencies. We have to do training every day in normal patients, and then we will be successful in critical situations and in emergency situations. Everybody has to be familiar with it. The nurses, the doctors, everyone. This is why we need continuous training. We use video laryngoscopy for every intubation. But direct laryngoscopy skills have to be practiced as well. And when we just turn around the monitor, we can do direct laryngoscopy as well. So we have to keep the skills high. The training of the hand-eye coordination is important. But this is, again, on a daily clinical practice, is easy to perform. One system for a broad field of application. This is why we chose the CMAX system. We have the video laryngoscopes, we have the bonfils, we have the flexible scopes. So all in one on a tiny little trolley. The monitor is important because on the monitor, everyone, every assistant, every teacher can see the things immediately. So they can add you another hand or help. Because when they do something on the patient, they can see the effect immediately on the monitor without having any communication with the person doing the intubation. And it's an excellent device for teaching. This is why we are using on a daily clinical practice. Excellent tools are important, but the correct use too. This is what we have to keep in mind. We can use the best stuff, but if we are not trained appropriately in it, we will not be successful. And I'm very sure that her father had the best in mind when he bought the helmet for her. But if she used the helmet the wrong way, she probably harms more than she protects. This is why we have to train all the equipment we are using or we are planning to use in an emergency situation. Use it in daily clinical practice. And with that, I would like to thank you for your kind attention. It is a great pleasure for me.
All right. Thank you, Professor Puhringer, for giving such elaborate presentation, especially about the use of video laryngoscopy in the COVID-19. So let us begin our session. I would like to introduce the speakers. Yeah. So this session will talk about the airway management. We will have 3 speakers. Dr. Andi Wijaya will also serve as the chairperson. I think this is not the first time, yeah, Dr. Adi. And then Professor Andre van Zundert from the Australia and Dr. Holzki from Germany. So I think I will introduce Dr. Ade as the first speaker. Dr. Ade is the anesthesiologist in the Department of Anesthesiology and Intensive Care in FKUI RSCM, also at the Cipto Mangunkusumo Hospital. I think she is master in the Pediatric and also in the airway management. So I think I will give time for Dr. Ade to start her presentation.
Okay. Let me share my screen. Okay, is it okay? Is my screen okay?
Yes.
Okay. Thank you, Krista. Good afternoon, everybody. I'm honored to be here with all my mentors in airway management, Prof. Puhringer, Prof. Andre van Zundert, and of course, Prof. Holzki. How are you, Prof? And thank you, Dr. Susulo, for inviting me. I will cover the topic about how to prepare the patient and the airway when we want to perform awake tracheal intubation. I'm sorry, and for the most benefit of Indonesian audience, I will speak in Bahasa, but my slides will be in English, so you can easily join us. Okay, our objective kita pada sore hari ini adalah yang pertama mengenai awake tracheal intubation. Pada sesi kali ini saya tidak akan membahas mengenai teknik, tapi lebih kepada bagaimana kita menyiapkan pasien, karena persiapan pasien itu sangat penting instead of the procedure itself. Jadi bagaimana apa sih sebenarnya awake tracheal intubation dan apa konsekuensinya bagi pasien. Kemudian bagaimana persiapannya, baik dari psikologi, farmakologi, equipment maupun the personel yang akan melakukan tindakan tersebut. Kemudian bagaimana melakukan oksigenasi dan monitoring. Oksigenasi dan monitoring ini terkait tindakan yang akan kita lakukan selama kita melakukan prosedur. Kemudian apa yang bisa kita berikan sebagai analgetik baik topikal maupun regional anesthesia, dan bagaimana kita menyiapkan kalau terjadi kegagalan. Baik, kalau kita berbicara mengenai awake tracheal intubasi atau intubasi sadar, sebenarnya kita lihat ini gambar-gambar di bawah ini, kita melihat bahwa kita kerap kali kita mendapatkan pasien-pasien yang predicted difficult. Selama ini kebanyakan guidelines yang ada itu terutama memberikan informasi bagaimana kita melakukan tracheal intubasi pada yang unpredicted, tapi tidak terlalu banyak guidelines yang ada yang memandu kita untuk melakukan tracheal intubasi pada pasien-pasien yang predicted, yang sudah terprediksi akan difficult. Kalau kita lihat awake intubation itu, awake tracheal intubation itu biasanya dilakukan pada pasien elektif dan dia sudah terprediksi akan terjadi kesulitan jalan nafas. Mohon maaf, pasiennya banyakkan anak karena I'm a pediatric anesthetist. Kemudian kalau kita lihat awake tracheal intubasi itu sebenarnya merupakan tindakan yang aman, salah satu tindakan yang aman yang dipertimbangkan kalau kita mendapatkan pasien yang predicted difficult airway. Kemudian namun tekniknya sendiri, teknik dari intubasi sadar ini itu sangat menstimulasi ya, sangat memberikan rangsangan kepada pasien dan menyebabkan pasien itu merasa tidak nyaman atau bahkan nyeri dan bisa menimbulkan bahaya gangguan hemodinamik maupun terjadi efek traumatik pada pasien. Nah, awake tracheal intubasi ini nggak mungkin kita lakukan pada ini pasien-pasien yang younger age, kayak pada pasien di gambar ini, pasien yang psikopatologi atau pasien dengan gangguan psikiatri atau pasien-pasien dengan gangguan kognitif, di mana pada awake tracheal intubasi itu kita sangat membutuhkan kooperasi dari pasien. Jadi ini menimbulkan satu permasalahan tersendiri kalau kita mau melakukan awake tracheal intubasi pada pasien dengan permasalahan jalan nafas yang sudah terprediksi, dan kita tidak bisa melakukannya atau sangat membahayakan pasien kalau kita melakukannya pada kondisi pasien dalam keadaan teranestesi. Kalau kita melakukan, sebelum kita melakukan tata laksana jalan nafas, kita sangat perlu melakukan pemeriksaan yang detail untuk jalan nafasnya. Dan dengan pemeriksaan yang detail itu, yang lengkap, kita sebagai anestesi kita bisa menentukan sebenarnya kita akan melakukan rencana prosedur kita seperti apa, dan bagaimana kita mensecure jalan nafasnya dan mempertahankan oksigenasi. Kemudian kalau kita berbicara mengenai strategi untuk difficult airway, jadi perencanaan kita untuk bagaimana kita melakukan tata laksana kesulitan jalan nafas itu sangat diperlukan kalau kita mendapati pasien yang dia nggak bisa diventilasi dengan face mask. Jadi kita nggak bisa meletakkan face mask di dalam muka pasien. Kemudian kemungkinan kesulitan untuk melihat laring atau memvisualisasi laring, atau kita nggak mungkin juga untuk melakukan supraglottis airway device, untuk memasang supraglottic airway device, baik itu LMA atau iGel atau yang lain-lain, atau bahkan kemungkinan kita sulit untuk melakukan krikotirotomi, misalnya pasiennya ada massa gitu di tiroid. Kita sudah memprediksi dia ada kemungkinan kesulitan intubasi, tapi kalau kita mau mencoba dalam mengintubasi pasien dalam keadaan pasien tertidur, kita nggak punya akses kalau ternyata terjadi kesulitan dan kita nggak bisa menemukan, kita tidak bisa melakukan krikotirotomi. Kalau awake tracheal intubasi itu melibatkan membutuhkan kita memasang ETT dalam keadaan pasien sadar dan bernafas spontan. Sadar ini mungkin slightly sedate, tapi dia sadar. Jadi kesadarannya itu tidak benar-benar hilang, tapi dia mungkin bisa diberikan sedikit ansiolitik, tapi dia tidak tertidur. Dan pasiennya bernafas spontan untuk memungkinkan jalan nafasnya itu aman sebelum kita melakukan induksi anestesi. Jadi dia harus cupnya sudah harus terpasang dulu sebelum kita melakukan induksi anestesi. Jadi maksudnya dari awake tracheal intubasi itu kita memasang cup pada saat pasien masih kondisi sadar. Apa sih yang harus kita lakukan kalau kita mau menyiapkan pasien? Persiapannya itu bisa persiapan psikologi, farmakologi, persiapan monitoring, serta persiapan personelnya sendiri. Kita pertama melihat dulu persiapan psikologi. Kita tahu bahwa pasien itu datang ke rumah sakit itu dia pasti perasaannya tidak menentu. Dia ada ketakutan atau ada kecemasan terhadap apa yang akan dia hadapi nanti. Nah, hal itu menyebabkan kondisi ansietas atau kadar kecemasan pasien itu cukup tinggi, walaupun kita belum tahu nih pasiennya dengan apa. Nah, pada saat kita melakukan kunjungan pra-anestesi, kita bisa melakukan assessment terhadap kondisi pasien, dan itu merupakan satu kesempatan bagi si anestesi tersebut untuk dia bisa mendapatkan kepercayaan atau trust dari pasien, dan pasien bisa kita bujuk untuk bekerja sama dan untuk menurunkan kadar dari ansietasnya. Nah, pada saat kunjungan pre-anestesi itu kita bisa mengidentifikasi sebenarnya pikiran pasien apa sih, kemudian bagaimana perasaannya dia, bagaimana sikapnya dia menghadapi penyakitnya, atau bagaimana sikapnya dia setelah kita jelaskan. Itu bisa kelihatan dan kita bisa menentukan nanti kira-kira plan kita mesti bagaimana supaya kita bisa mendapatkan kooperasi atau kita bisa mendapatkan kerjasama yang baik dari pasien. Pasien juga harus diberikan informasi mengenai sebenarnya apa yang akan dia hadapi. Misalnya kita bilang, nanti kita lakukan apa dulu, kemudian kita akan melakukan apa. Dan semua tindakan itu akan menyebabkan pengalaman yang tidak menyenangkan buat pasien. Karena memang awake tracheal intubasi itu sangat tidak menyenangkan untuk pasien. Kemudian kita juga harus menjelaskan alasannya kenapa kita perlu mengamankan jalan nafas pada kondisi di mana dia masih sadar. Kenapa sangat penting kita melakukan itu. Kemudian kita juga harus meminta konsen, yang konsennya itu harus jelas. Kita menjelaskan semua prosedur dan bahwa kita akan melakukan tata laksana jalan nafas dengan kondisi yang pasiennya sadar, dalam kondisi pasiennya yang sadar. Bagaimana persiapan personel? Personel itu berarti kita atau pelaku dari tindakan. Kita tahu bahwa awake tracheal intubasi tersebut itu bikin kita stres. Fisik, mental, dan psikologis itu kita stres. Kalau bisa sih, kalau dapat pasien-pasien kayak gitu, dikirim aja deh ke Jakarta atau rujuk aja deh atau apa deh gitu. Kita pasti pengennya begitu. Tapi bagaimana kalau pasien itu emergency ada di depan kita? Dan kita harus melakukan tata laksana jalan nafas pasien, ditambah lagi misalnya kondisinya ada COVID lah, atau ada critically ill lah, atau ada yang lain-lain, dan kita nggak bisa rujuk. Nah, itu yang akan menambah stres dari si operator tersebut. Nah, stres dari si operator tersebut dia akan mempengaruhi kemampuan dia untuk melakukan tindakan. Kemampuan dia untuk mengerahkan seluruh kemampuannya itu tuh jadi terganggu kalau dia ada stres. Untuk itu kita sangat memerlukan teamwork, good komunikasi, dan persiapan yang appropriate untuk memitigasi kemungkinan atau tantangan yang akan kita hadapi ke depan berikutnya nih. Nah, sangat penting kita punya asisten yang terlatih dan kompeten. Jadi kalau misalnya kita mau melakukan ini besok nih kita ada kasus awake tracheal intubasi. Nah, kita cari deh tuh asisten yang bisa nemenin yang dia mampu untuk melakukan. Nah, safety itu nggak boleh terpengaruh oleh tekanan karena waktu. Misalnya gitu operatornya rese nih, ayo cepet udah lama gitu, memburu-buru atau ada staff lain yang memburu-buru kita. Nah itu safety itu tidak boleh terpengaruh oleh itu. Jadi take your time, kita bisa mengambil waktu kita dan mempersiapkan pasien dengan baik dan membuat diri kita juga tenang. Jadi kita mesti mengutarakan nih rencana kita apa sih dengan semua tim yang ada di kamar operasi, supaya kalau nanti terjadi sesuatu semua udah langsung bisa siap untuk sudah bisa tahu apa yang harus dia kerjakan gitu ya. Nah, kita mesti memberitahu juga nih skilled anesthetic colleagues. Jadi kita tahu di rumah sakit kita ini yang paling skillful, belum tentu yang paling senior ya, tapi yang paling skillful anestesi itu siapa ya? Jadi kita udah halu-halu nih. Ini saya bakalan dapat pasien ini nih, halu-halu deh gitu. Jadi kita di sini jelas bahwa successful dari awake tracheal intubasi itu dia nggak tergantung dari senioritas, tapi experience. Jadi semakin banyak experience kita akan semakin kompeten. Ini dari Difficult Airway Society, mereka merilis teknik untuk melakukan awake tracheal intubasi yang di-launching tahun 2019 pada saat World Airway Management Meeting di Amsterdam. Di-launchingnya pada saat itu, kenapa mereka harus melaunching ini? Karena sebenarnya awake tracheal intubasi itu memiliki success rate yang tinggi. Jadi sebenarnya dia bagus gitu, awake tracheal intubasi ini. Dan profilnya low risk, sebenarnya tidak membahayakan pasien juga gitu. Jadi mereka membuat guidelines ini untuk meningkatkan awake tracheal intubasi, karena pada saat itu di London itu di Inggris itu awake tracheal intubasi itu tuh masih underrated, sehingga banyak kejadian-kejadian yang adverse event pada pasien yang difficult to intubate, yang sudah terprediksi difficult. Jadi karena mereka nggak mau melakukan awake tracheal intubasi karena memikirkan kepuasan pasien kan. Kepuasan pasien pasti nggak puas tuh Pak kalau kita awake. Tapi kalau misalnya itu untuk menyelamatkan nyawanya atau untuk safety, ya kita sebenarnya harus melakukan. Jadi ini untuk meningkatkan penggunaan awake tracheal intubasi dengan memberikan guidance yang jelas. Jadi ini lebih simpel dan sangat jelas. Saya tidak akan berlama-lama dengan teknik. Dan bagaimana dengan persiapan farmakologi? Jadi persiapan farmakologi itu kita menyiapkan obat-obatan yang bisa kita gunakan untuk membantu kita dalam menyiapkan pasien dan juga menyiapkan si Airway-nya sendiri nih supaya siap. Karena Airway itu kan sangat mudah terangsang ya, mudah terstimulasi, sehingga dia juga harus dipersiapkan. Jadi kita harus menggunakan kombinasi beberapa obat untuk menurunkan ansietas. Kita bisa menggunakan sedasi, obat-obat sedasi dan obat-obat yang lain. Kemudian kita bisa memberikan analgesi, yaitu topical anesthesia dengan limited amount, jumlah sedikit aja analgesia sistemik. Kemudian kita juga bisa menggunakan regional anestesi. Kemudian tujuannya berikutnya untuk memprovide jalan nafas yang clear, yang bersih dan kering. Karena kalau dia hiperreaktif itu agak menyulitkan tuh gitu. Jadi bisa diberikan antisialagog, tapi harus hati-hati kalau kita memberikan antisialagog. Jadi misalnya kita memberikan SA, udah pasiennya lah stres, ditambah dikasih SA, tambah takikardi gitu. Jadi pasiennya takikardi itu kan hemodinamiknya juga nggak bagus gitu. Kemudian ada beberapa yang diberikan vasokonstriktor topikal untuk membuat jalan nafas itu lebih kering. Kemudian bronkodilator dan steroid juga bisa diberikan untuk pasien yang kita tahu dia ada hiperreaktif bronkus atau jalan nafas atau ada riwayat asma, itu bisa kita berikan. Kemudian obat-obatan yang dapat mencegah terjadinya aspirasi dari isi lambung, misalnya H2 reseptor blocker atau agen-agen prokinetik. Bagaimana dengan sedasi dan analgesia yang intravena? Nah, biasanya kita bilang kasih sedasi sedikit deh. Jadi sebenarnya definisi dari minimal sedasi itu adalah obat yang dia diberikan untuk pasiennya, jadi supaya pasiennya itu bisa berespon, dia masih bisa berespon secara normal untuk terhadap verbal command, jadi terhadap perintah verbal, sementara airway dan ventilasinya masih spontan, airway-nya clear, dan fungsi kardiovaskularnya tidak terpengaruh. Kemudian kalau kita tahu bahwa penggunaan sedasi itu dapat menurunkan ansietas dan juga discomfort, dan pasiennya tuh bisa amnesia, jadi dia bisa lupa setelah dilakukan apa gitu. Nah, sedasi ini dia bisa meningkatkan acceptance dari pasien, jadi dia bisa pasien itu jadi lebih tenang dan jadi lebih kooperatif. Tapi juga dia bisa menyebabkan obstruksi dari jalan nafas. Jadi pemberian sedasi ini membutuhkan pemberian yang hati-hati dan kita membutuhkan monitoring yang ketat. Jadi kita harus mewaspadai terjadinya oversedasi, termasuk respiratory depresi, jalan napasnya jadi nggak secure lagi, nggak paten lagi, kemudian dia hipoksia, aspirasi atau cardiovascular instability. Ini beberapa obat yang bisa dipakai untuk sedasi, light sedasi. Propofol bisa dipakai dengan dosis yang sangat kecil, pakai TCI, atau kita bisa pakai one shot dengan dosis yang lebih kecil dari biasanya, 0,5 sampai 1 miligram per kilo. Kemudian midazolam juga bisa dipakai, biasanya paling sering dipakai adalah midazolam. Sekarang kita mulai banyak menggunakan dexmedetomidine. Dexmedetomidine memberikan efek sedasi yang cukup kuat, tapi analgetiknya dia nggak terlalu kuat, tapi hati-hati dengan efek bradikardinya. Kemudian sebagai analgetik IV kita bisa menggunakan remifentanil. Remifentanil ini tapi efek depresi pernapasannya juga bisa sangat kuat. Jadi harus hati-hati pemberiannya dan kita memberikan secara titrasi atau dengan menggunakan TCI. Fentanyl juga bisa diberikan, alfentanil atau sulfentanil juga kita bisa memberikannya. Bagaimana dengan topikal dan regional anestesi? Topical analgesia yang sering diberikan adalah lidocaine. Lidocaine yang tersedia di pasaran itu ada 2% sampai yang spray itu 10%. Di kita nggak ada yang 4%. Jadi sebenarnya yang paling efektif untuk topical analgesia itu adalah yang 4%. Tapi kita nggak punya. Jadi kita bisa pakai yang 2% yang ada di sediaannya yang ada di kita. Kemudian bisa juga kita menggunakan lidocaine dengan sedikit tambahan adrenalin atau kokain. Kokain di kita adanya ilegal ya, kita nggak ada yang legal. Kemudian bagaimana cara menyemprotkan topikal itu? Bisa kita spray langsung dari botolnya, kita spray langsung. Bisa juga ada beberapa yang si obatnya itu tuh ada kasa yang kasa gulung, bukan kasa gulung, kasa yang kayak pita gitu ya. Itu dicemplungin, kemudian itu dipakai untuk melap jalan nafas. Kemudian bisa pakai lidi kapas. Kemudian ada McKenzie teknik, nanti bisa dilihat gambarnya. Kemudian ada mucosal atomization device, itu bisa membuat terspray. Jadi cairannya itu bisa terspray. Kemudian kita bisa juga menggunakan inhalasi atau inhalasi lidokain. Kemudian bisa juga nih pakai epidural kateter, atau ada yang pakai dilatornya CVC, atau pakai segala macam deh teknik yang bisa digunakan untuk bagaimana kita bisa mengaplikasikan si topikal ini ke airway. Ini beberapa contoh yang saya ambil dari websitenya NYSORA. Bisa diinhalasi. Ini yang med device. Jadi dari cairan kemudian dia bisa terspray, jadi partikelnya itu bisa jadi lebih kecil. Ini yang McKenzie teknik. Ini bisa nih kita buat sendiri, ini seperti ini. Jadi ini lidokainnya, kemudian dengan ini disambungkan ke oksigen. Jadi selang ini disambungkan ke oksigen sehingga oksigennya dengan oksigen tekanan yang cukup tinggi, karena ini selangnya kecil kan, jadi dia ada resistance di sini, sehingga dia akan membantu menyemprot lidokain yang disuntikan dari sini. Jadi di sini ada udara yang keluar, di sini ada lidokain, dia akan terspray ke sini. Ini McKenzie teknik. Ini beberapa lidokain yang tersedia. Ini yang dilatornya CVC. Ini bisa juga kita pakai, ini dikoneksikan ke speed langsung, dan itu dia bisa masuk ke dalam dan kita bisa melakukan spray di situ. Ini berbagai macam teknik yang bisa kita gunakan. Kemudian regional anestesi, sebenarnya apa aja sih yang harus diblok? Yang pertama adalah glossopharyngeal nerve, superior laryngeal nerve, dan translaryngel block. Jadi ini glossopharyngeal block. Jadi dari dalam mulut kita blok di atas tonsil ya. Kemudian superior laryngeal block dengan landmarknya seperti ini, atau pakai USG juga bisa. Kemudian translaryngel block. Translaryngel block ini kita menyuntik obat anestesi lokal ke dalam trachea. Jadi kita aspirasi terus keluar bubble di trachea. Kemudian kita agak sedikit miringkan dan kita arahkan spet kita ke arah sefalat. Kita arahkan ke arah sefalat supaya obat anestesi lokal kita bisa menyemprot ke dalam laring. Kemudian equipment, peralatan apa aja sih yang harus kita siapkan? Jadi yang paling sering digunakan adalah video laryngoscope dan fiber optic intubasi. Ada juga yang other device-nya, kita bisa menggunakan bone fields, kita bisa pakai bantuan gam elastik buji dengan konvensional laryngoscope. Nah, yang perlu kita perhatikan adalah kita harus mulai menyiapkan airway chart. Jadi ini airway chart tadi seperti yang Prof. Puhringer tunjukkan. Airway chart-nya ini yang sophisticated, tapi ini kita lihat yang di samping-samping ini adalah airway chart yang disiapkan oleh teman-teman kita yang sudah mengikuti workshop airway management CPD-nya P2KB Perdatin. Jadi setelah mengikuti workshop, kami minta mereka membuat airway chart, airway trolley airway, di mana semua peralatan airway yang mereka punya di rumah sakit itu mereka kumpulkan jadi satu. Ada yang pakai bag, ada yang cuma di meja mayo, di sini juga ada yang cuma ditata di atas dengan segala macam video laryngoscope-nya, ada yang pakai troli, ada yang pakai box, dan lain-lain. Jadi sebenarnya kita bisa memprovide sendiri airway chart kita. Apa yang harus dimonitoring selama tindakan? Yang pertama basic monitor pastilah elektrokardio EKG, kemudian non-invasive blood pressure, pulse oximeter, atau standar monitoring yang itu sudah harus wajib disiapkan atau sudah harus terpasang. Kemudian additional device itu dia untuk memastikan lokasi dari si cup pada saat kita mau coba memasukkan. Dari Difficult Airway Society mereka menetapkan ada 2-point check, yaitu visualisasi dan kapnograf. Yang pertama visualisasi, kalau kita pakai fiber optik kita bisa melihat dinding dari trachea dan karina. Kemudian kalau dengan video laryngoscope kita bisa melihat bahwa ETT itu memang masuk ke dalam laring. Kemudian kapnograf kita bisa melihat bahwa ada kapnografnya untuk melihat bahwa dia nggak ke esophageal intubasi. Oksigenasi kalau kita bilang preoksigenasi nggak akan cukup. Jadi oksigen itu harus terus diberikan selama kita melakukan tindakan. Jadi selama kita melakukan awake tracheal intubasi, oksigenasi itu harus terus diberikan. Jadi tujuan kita sebenarnya untuk melakukan tata laksana jalan nafas adalah oksigenasi. Jadi successful dari tracheal intubasi itu belakangan. Kalau oksigenasi kita bisa dapat, ya itu dipertahankan gitu. Nah, banyak literatur yang menyatakan bahwa transnasal modified rapid insufflation ventilatory exchange atau TRIVE itu bisa ditoleransi oleh pasien. Jadi seperti ini pasiennya, dan dia akan memperpanjang apnea time dari pasien. Kalau ternyata pasiennya harus apnea karena kita kasih fentanilnya kebanyakan gitu, dan dia akan memaintain oksigenasi selama kita melakukan prosedur. Ada beberapa, kita menggunakan nasopharyngeal airway juga bisa, atau kita menggunakan ini supernova namanya. Ini yang sekarang terkenal sekali karena COVID, HFNC atau OptiFlow. Nah, kita juga harus siap untuk failure. Ini dari Difficult Airway Society, mereka membuat guidelines bagaimana kalau awake tracheal intubasi kita nggak sukses. Jadi ada algoritma ini, dan algoritma ini harus kita pikirkan pada saat kita melakukan awake tracheal intubasi. Sampai terakhir adalah kita bisa FONA apa enggak ya, front of the neck access. Harus hati-hati. Jadi yang disebut dengan failure adalah jumlah attempts-nya itu harus dibatasi 3 kali. Jadi ada 3 kali yang dilakukan oleh first provider, kemudian ada 1 kali lagi yang dia untuk experience operator. Jadi 3 kali, begitu 3 kali si operatornya nggak bisa, dia harus manggil 1 lagi yang lebih senior atau yang lebih experience. Nah, begitu 3 plus 1 ini gagal, itu kita sudah bisa menyatakan bahwa intubasinya gagal. Baik, yang terakhir saya ingin menyampaikan rekomendasi dari Difficult Airway Society untuk awake tracheal intubasi. Yang pertama, awake tracheal intubasi harus dipertimbangkan kalau pasien kita itu terprediksi ada kesulitan difficult jalan nafas. Jadi nggak usah takut. Kemudian kita mesti punya nih cognitive aid checklist seperti yang tadi dari Difficult Airway Society itu bisa di-download gratis. Kemudian suplemental oksigen harus selalu diberikan selama tracheal intubasi. Kemudian efektif topikalisasi harus establish dan harus di tes, dan hati-hati dengan maksimum dosis dari lidocaine. Kemudian penggunaan dari sedasi harus hati-hati dan boleh diberikan sedikit sedasi. Kemudian sedasi should not, nggak boleh digunakan sebagai pengganti topikalisasi yang tidak adekuat. Jadi dia harus hati-hati diberikannya. Jadi nggak boleh, ya udah kan kita udah kasih sedasi atau udah kasih analgetik, nggak usah dikasih topikal lagi. Nah, the number of attempt harus dibatasi 3+1. Kemudian anestesi hanya boleh diberikan, hanya boleh diinduksi, pasien hanya boleh diinduksi setelah 2-point check itu harus terkonfirmasi. Nah, yang terakhir, semua departemen harus mensupport anestesi untuk mendapatkan kompetensinya. Jadi kalau misalnya kita bilang ini pasiennya nggak difficult, tapi kita mau, tadi seperti Prof. Puhringer bilang, kita bisa training pada pasien yang normal, itu semua harus mensupport itu. Jadi baik dari instalasi bedahnya maupun dari surgeon, itu mereka harus membantu kita juga supaya kita bisa maintain, mempertahankan skill, terutama kalau kita harus berhadapan dengan awake tracheal intubasi. Jadi kalau kita mendapati kasus difficult airway, tetap tenang dan evaluasi lagi. Terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Chris?
Ya dok, boleh lanjut dok.
Oke, baik. Pembicara kita berikutnya adalah Profesor Andre van Zundert. Profesor Andre van Zundert adalah profesor dan chairman dari Department of Anesthesia dan Perioperative Medicine di University of Queensland, Brisbane, Australia. Prof. van Zundert sudah tidak asing lagi dan sangat banyak publikasinya terkait dengan jalan nafas. Prof. Andre, the screen is yours.
I thought you were going to give the presentation which I've sent to you.
Yeah.
Thank you.
In a minute.
Okay.
Hello, greetings from Brisbane, Australia. Thank you very much for the invitation to give a lecture on obtaining optimal positioning of a laryngeal mask airway by direct vision. Is the exercise worldwide? I'm going to talk about vision-guided technique using video laryngoscopy to insert supraglottic airway devices. Now, how do I know that supraglottic airway devices are positioned adequately? The golden standard thus far is the oropharyngeal leak pressure. And for the first generation, it should be around 20 centimeters of water. For the second generation, it should be 25 or more. And we are using fiber optic evaluation to find out about the position. But you see two of these images, very few options for corrections are left. Now, I question what is the value of the oropharyngeal leak pressure and intracuff pressure if one does not know the exact position. Just recently, in February this year, Acta Anesthesiologica Scandinavica published our editorial that it is time to consider supraglottic airway device oropharyngeal leak pressure measurement more objectively. Now, how do I know supraglottic airway devices are positioned adequately? We have on the left-hand side the blind technique and on the right-hand side the vision-guided insertion technique. The blind technique, in 50 to 80% of all supraglottic airway devices are malpositioned. We call that a failed supraglottic airway device. And that's based on imaging and on MRI. The vision-guided technique is better than the blind technique because what we can do better. And this is how we insert it. And the patient is positioned in the supine position. We put the supraglottic airway device in by pushing against the hard palate, going all the way down with the distal cuff inserted into the esophagus entrance. Okay, now it is inflated and we have two seals, the first seal and the second seal. So that is virtually the two techniques how you insert it. So the first seal is an
mati ya. Bisa nggak bisa ya? Kalau dari lu bisa nggak nih? Coba dulu nih.
Di sini.
Dari lu yang umpetan lu.
Sorry, Prof. Andre, we'll try to make it full screen.
Bisa ya? Skip dulu ya. Yuk. Oh ya, Mas Faris nggak di sini. Nggak dia langsung dok. Oke. Aduh, nggak hang lagi.
Sorry for the
The vision-guided technique is better than the blind technique because what we do better. And this is how we insert it. The patient is positioned in the supine position. We put a supraglottic airway device in by pushing against the hard palate and going all the way down with the distal cuff inserted in the esophagus entrance. Okay, now it is inflated, and we have two seals: the first seal and the second. So that is firstly the two techniques how you insert it. So the first seal is an inflated cuff sealing against the entrance to the esophagus, against the entrance to the airway, and the second seal is the inflated distal cuff blocking the entrance to the esophagus. At the same time, aspiration is protected. Such. An optimal fit for supraglottic airway devices leads to a better function. The function from an anatomical perspective and a functional perspective. The tip of the distal cuff should block the upper esophageal sphincter. That's one thing, and the cuff should occupy the complete hypopharynx here. That's the second seal, and this is the first seal. The epiglottis should be flattened between the base of the tongue and the inflated cuff, the proximal cuff. Okay, so it should be flattened and it should sit on the outside. You can see it in different positions as well in radiology and in a mannequin sitting. From a functional perspective, the functional barrier, there should be a functional barrier with adequate gas exchange and no trauma. So you see three perfect positions here. The epiglottis is flattened between an inflated proximal cuff and the base of the tongue. And the same here, base of the tongue, flattened epiglottis on the outside of an inflated LMA supreme. And this is the same, but then for the... So the first seal is of importance, and we do not want to have any leakage. For instance, in this particular situation, you can't inflate because there's no cuff with an eye gel. So sometimes we see these gaps. These gaps can also result in leakage because of an inflated cuff of an LMA supreme, and that's a PVC one, and you see these foldings. They happen about 80%. Now, if you want to insert a supraglottic airway device, just above the tongue, it's always confronting that epiglottis. And if you push hard, the epiglottis will downfold and may result in leakage. Or this is an awake patient. You see he's breathing in and out, and you see the tongue is here. And we want to insert the supraglottic airway device and go around the epiglottis, and insert the distal cuff into the esophagus, making sure that there's an open airway to the trach. In a comatose patient, such as is the case under anesthesia, we see that the tongue is now obstructing that area here, and you need to lift the lower jaw in order to create distance between the base of the tongue and the posterior pharyngeal. So this is the blind insertion technique, as you can see here. Now, the correct position is like this. The tip of the epiglottis is aligned with the tip of the proximal cuff. And the epiglottis is flattened between the base of the tongue and the proximal cuff, which is inflated. Now, this should be aligned. This is absolutely not aligned. This is also not aligned. This is when the cuff is too big and the size is too large, it is hyperinflated, or the insertion is not deep enough to superficial. On the other hand, the insertion is too deep, the size is too small, or the cuff is hyperinflated. So we get malpositions due to these two, and you get sometimes even obstruction. Now we had the pleasure that our work was put on the cover of the British Journal of Anesthesia, malpositioning of supraglottic airway devices, preventive and corrective strength. Now, this is what you see. This is the epiglottis in the radiography, and you see it's always facing that posterior pharyngeal wall. So anything that you put into the mouth you will be confronted with an epiglottis, and usually it's downfold 80% of the time. Now, these images are in mannequins. These are images taken from real patients. You see, that is the ideal situation. Epiglottis flattened between the posterior of the tongue and inflated proximal curve. Same here. Okay. This is when it is too deep. If it is too deep, the size is too small, it's not enough inflated, then you see this. It's not aligned. Okay? If it is superficial, you see it if it is superficial, now then it risks to be dislocated because it can come out of the hypopharynx, creating a big leak. In this situation, you see the epiglottis is now inside the bowel of the device, and it's even downfolded. And here it is not even downfolded, but here it is downfolded. So if I go through the tube, and look inside, this is what you can see, and this is, well, the epiglottis still can be seen, and that's a good situation. Okay? Now, if there's still a leak, like in this situation with a Wijaya, that creates a leak, and that's not what you want. Leaks can also be seen with an inflated PVC cuff, whereas with silicone cuff, you usually do not see these foldings. The tip can be downfolded. You see here the epiglottis. The epiglottis is downfolded, but also the tip is downfolded. Also, that creates a leak and not a prevention of aspiration. Here the tip is going between the two vocal cords. I will show that in a moment. The epiglottic downfolding or folding double of the epiglottis is also possible. Now, if you use your fiber optic scope to find out is the positioning adequate, this is what you need to see. Yeah, you see the vocal cords, the arytenoids, and even the entrance to the esophagus. Yeah? Clearly, these are good positioning. Sometimes you see a little bit about the epiglottis, the posterior side of the epiglottis, as in those two cases. Again, it's not bad. And look at the same time, the epiglottis bars is bulging towards us instead of to the patient. Yeah? And sometimes there's no even any connection up. So if the epiglottis is in the bowel, like here, or is even downfolded, it can lead to air leaks or to obstruction and poor obstruction possibility. You see images from here, and these are two patients where you see this image, and this image is translated in two other patients with complete malpositioning, as you can see here, due to the fact that the epiglottis is now protruding through the mask aperture bars, not even connecting, and sometimes there's a complete obstruction, as you can see. So this is the overall picture of all the models of all the malpositions that you can see. It happens with all the devices, and I've given you here a few of them, with deflated cuff, optimal position, epiglottic downfolding, folding of the proximal cuff, double folding, and these are two masks. So it happens with all the devices because it's a blind technique. Now, correct insertions, you see the epiglottis, go underneath the epiglottis with the tip of the laryngeal mask, put it into the hypopharynx. Yeah. Once it's there, inflate the cuff, yeah, and you will see that the epiglottis will be flattened between the epiglottis will be flattened between the base of the tongue and the inflated cuff, and it should be aligned. That tells you it's in the right position. See here the epiglottic down, the distal cuff folding, and this is the malposition where the tip of the device is in between the vocal cords, as you can see in here in circumstances. You've seen this is too deep, this is too superficial, and you see this is too deep, too small a device, not enough inflated, not big enough sizes. It's completely hidden away, as you can see. Or the reverse, whether the size is chosen too large, it's inflated too much, it's too superficial, and then it risks of dislocating from its position. The dislocation, malalignment, the tube airway and the glottic entrance, there's air leak, possibly an obstruction, and epiglottic positioning in the bowel device and gas exchange impairment and obstruction. So that's not good. It's a bad situation. Epiglottic folding double, you see here 6 space. It's not what we want. The leak is usually due to foldings in the proximal cuff, as you can see here in 3 occasions, whereas with silicone, you see this is an LMA Classic, this is an LMA Protector, and this is an LMA. So we developed a grading system. Grade 1 is this position here. Perfectly see that supraglottic airway devices with the correct size. Epiglottis is resting on the outside of the device, on the outside of the inflated proximal cuff, and it should be flattened between the base of the tongue and the inflated cuff. Normal capnography should be seen, good air entry, excellent gas exchange with oropharyngeal leak pressures above 25 centimeters of water, intracuff pressures between 40 and 60 centimeters of water, and a saturation above 95%. If that is the case, proceed with anesthesia and surgery. Grade 2 is you see marginally positioned supraglottic airway devices. With the fiber optic now you see the epiglottis. Adjust in maneuvers, adjusting the size, adjusting a band, it's possible. And because you do not want to have an air leak, an abnormal capnogram, or impaired gas exchange. You will end up with lower values of the oropharyngeal leak pressure, not 25 but lower, cuff pressures, not 40 to 60 but lower, and saturations which are lower than this one. This is still acceptable. This is acceptable, you still can proceed. And grade 3 are these ones. This is for the cords. You see the distal cuff is entering the trachea, or the epiglottis is protruding between the mask apertures. These are clinically unacceptable positions, with creating severe gas leak, airway obstruction, and inadequate ventilation, with very low values of the oropharyngeal leak pressure, intracuff pressure, and low saturations. Adjusting maneuvers are required, and that can be jaw thrust corrections, cuff inflation correction, the size correction, or using a rail. I'm not going too deep into that, but you can read it in the British Journal of Anesthesia in 2017, the failed supraglottic airway device, an algorithm for optimally placed supraglottic airway devices on video laryngoscopy. The optimal position is in green, example of suboptimal position and what you need to do as maneuvers. So it's published in the British Journal of Anesthesia in 2017, and we also published the vision-guided placement of supraglottic airway devices prevents airway obstruction, prospective audit, where we demonstrate how often it happens. Ideally, no epiglottic downfolding and no seal, good seal and no leak, as you can see, 6-7. So the laryngeal mask airway, that is a fantastic tool. We are using it in more than 200 million of patients every year. Ideally, we use a second generation supraglottic airway device that is optimally positioned in the airway. Supraglottic airway devices can be used as a tube intubation conduit, according to the difficult airway algorithm. Secondary, so these are ideal features, but secondary features is the size of the supraglottic airway device, the cuff pressure, and oropharyngeal leak pressure. There are many issues, different brands, exact size, spacing characteristic, malpositioning, limitations of the vision-guided technique, and a perfect sitting device can still dislocate. We are not going. But just recently in the anesthetist, and it's in February 2021, where a guided versus a non-guided insertion of ambient organ in edentulous patient was compared. So they used the gastric tube to use as an insertion guide. 72 patients between 50 and 90 years old, and they found that the guided insertion technique did not improve oropharyngeal egress. But this is not a vision-guided technique. They do not use corrections. It's just a simple gastric tube, and they just use it as whereas a vision-guided technique, we are comparing LMA Supreme and an LMA Protector. And we did that as the very first study that proved that vision-guided insertion of adequately sized second-generation supraglottic airway devices positioned in an anatomically and functionally optimal position. We know that blind insertion techniques results in 50 to 80% of malposition. And look what we obtained with the vision-guided insertion technique. 96% or 94% of the LMA Supreme and the LMA Protector was immediately in the most optimal position, the grade 1, and a few were in the grade. So we wrote an article, editorial about the case, and we made the case for a third-generation supraglottic airway device facilitating direct vision placement. We think that we should not rely on subjective indicators or subjective assessment to estimate the correct placement. Oropharyngeal leak pressure is one of them. Third-generation supraglottic airway devices should be manufactured by the manufacturing industry of supraglottic airway devices, equipped with cameras and fiber optic illumination, so that we can evaluate during the vision-guided technique an optimal position of the supraglottic airway devices, and whether we have selected the correct size. That is what we can see. Vision-guided placement should become the gold standard, and I dream that once upon a time. Why going blind if you can see with supraglottic airway devices? We have shown you the position of the supraglottic airway device in an exact ideal situation with the alignment here, no epiglottic downfolding, no obstruction, and you can use it also for all your other devices. A nasogastric tube, an orogastric tube, or a temporal tube, where it goes into the esophagus, or an endotracheal tube, or as you can see here, how deep it should be inserted, or even a NIM tube for thyroid surgery. It is all possible thanks to that vision-guided technique. Greetings from Brisbane. Thank you very much for your listening to me.
Thank you very much, Prof, for the very informative presentation. I just know that the LMA could be that difficult. Okay, our last but not least speaker would be Professor Josef Holzki. Professor Josef Holzki is a consultant from Department of Pediatrics, University Children's Hospital of Liege, Belgium. Prof. Holzki, the screen is yours.
I have to press the green button.
Yeah, that's true. The green button, the share screen.
Okay.
Yeah, and then choose your slides.
Where are my slides?
Maybe you should open your
no
slide
need,
first.
No need.
Oh, no need.
No need. Just go to your slides. It should be down there. Yeah, that one.
Yeah.
Ah, here are my
Yes.
All right. And then put it in the slideshow, Doctor.
yes.
Fantastic.
Yes.
Is it there?
Yeah, it's there. But
Okay.
it is not in the full screen mode. Krisa, maybe you can help.
I have to,
Until again, yeah, you're right.
Yeah.
Yeah.
Okay.
It's okay now. Okay, then I can start. Well, thank
Yes,
you very
please.
much for inviting me to all of you and helping me to get into this system. Today, I want to talk about the correct knowledge of the anatomy of the pediatric larynx as the cornerstone of avoiding intubation trauma. This sounds a little bit funny because we have to consider that every pediatric anesthesiologist at least knows what the anatomy of the pediatric larynx is. But actually, this is not always the case. There were publications which doubted the traditional anatomical descriptions of the pediatric larynx because they said, oh, these old guys, the anatomists, they didn't know what they were saying. But we, the modern people, rely on radiological methods. And this was Littman. This study was neglected by us in a way, but Dalal and Tobias gave arguments which were very, very annoying and scaring for us, the so-called descendingly addressed old guys. They said, the cricoid cartilage is overly shaped. The narrowest part of the larynx is the glottic level. What is the reality behind this? The most annoying article was written by Tobias from Columbia University, a very well-known place. And he said, the pediatric airway may be not what we thought, referring to us, the old guys, but we didn't think about it. We didn't measure and so on. And what he published is, like you see here under A, the cricoid outlet is overly shaped. You cannot occlude it with a circular tracheal tube. You need a cuff tube, and then you can occlude the airway. But if you have a cuff tube, it never should stay in the outlet of the cricoid ring. A cuff tube belongs to the middle of the trachea. And here is just an example from a rabbit workshop which we made together with our friends in Singapore. You see, this is the trachea of a rabbit, which has the same size like that of an infant below 1 year of age. But the deflated cuff has an outer diameter which is larger than this, and the AP diameter of the trachea is even shorter. And you see how the folds impinge on the trachea in every single animal. But what is it in the real patient? Well, there were about 20 to 25 pediatric anesthesiologists who said, we cannot accept what Tobias said. It is wrong. But what could we do? We ended up with 4 people left. You see them here. Robert Carroll was the father of the high volume, low pressure cuff in adults, and he always warned to use this type of cuff in infants. Well, we found more than 1,200 individual measurements and depictions of the pediatric larynx in this literature. And we had strong arguments that the anatomists and the airway endoscopists are right. We published it in Pediatric Anesthesia in 2018. However, it was read, there was a lot of letters going back and fro, and it was, well, the people didn't really believe us. So what did we do? The first description, very good description of the pediatric airway was published in 1897, and Bayeux did calibrations of the pediatric larynx, and he found out he wanted to measure the circumference of the glottis. And he realized before he could use the largest tube which extended the epiglottis to the point that he could measure the circumference, he got stuck in the outlet. And if you cut open the cricoid arch, then you could measure this distance, and he could make the following. He calibrated the epiglottis and subtracted this distance, which is about 5 to 7 millimeters, and then he had the real size of the cricoid outlet. And he said, well, if you look at it from all sides, the outlet of the cricoid cartilage is the narrowest part of the pediatric airway, up to about 8 years. About 40 years later, Peter in Germany published a little booklet about the pediatric airway, and he did not only calibration, he measured. He measured exactly what is the pediatric larynx by make a transection of the larynx, and then he said, now let us have a look. There is the short arch, 3 millimeter, the lamina, more than 10 millimeter. And if you look carefully, the lamina is tilted backward, the arch a little bit forward. And he measured the outlet of the cricoid cartilage and came to the conclusion it's circular. It's maybe a little bit wider, but 1 or 2 or 3% of the AP diameter. So we have the cricoid cartilage with a circular outlet, but the upper part slanting down to the arch is ovally shaped. And this never got into the discussion in a full way with the people who relied on radiologic imagings. So then there was a paper by Eckenhoff in 1951, which we, anesthesiologists, at least the older generation, said, this is exactly what the pediatric larynx is. Namely, we have two parts of the cricoid cartilage, the posterior large part, 4 times higher than the arch, backward leaning, and the inferiorly positioned arch of the cricoid. Okay, but the problem was that Eckenhoff quoted this reference in the wrong way, and nobody could find them for more than 70 years, because my group, we needed actually 3 years to find these old papers. But Wijaya was quoted in every study, meaning between 51 and the 2020s, nobody really has read these papers, just quoted wrong references. Okay, so we thought we have to go into this problem in more detail. And here you can see that MRIs and CTs can easily make coronal sections through the larynx. And they said, well, but coronal sections say the glottis is the narrowest part. The outlet is wider, but we who intubate, who endoscope, who really are professional airway endoscopists know this is not the narrowest part, because this part here is immensely distensible. And if we intubate, we don't care about the distance from the glottis. We care about what is going in here. And if the tube is too large, you damage the mucosa. If it's too small, well, you might make to readjust by taking a smaller tube. And here again, if you look at this X-ray, and this is about the same like a MRI scan, a coronal section, you see, oh my goodness, here's the trachea. Oh, it becomes very narrow here. Here's the glottic level. Okay, the glottic level is the narrowest part. No, wait a minute. No, this again is a widely distensible part of the glottis and the immediate subglottis. Here we made a section from our study, which we finally initiated as an anatomical study, showing the same what Peter showed. And I cannot see it here, but it's a funnel-shaped larynx with a small arch, large lamina, and the cricoid outlet is definitely circularly shaped. But what is the problem with coronal sections? It is, if you make the coronal section here and look at this, then it's very small. You might not even see a little crevice which shows the lumen of the larynx. If you make the coronal section here, then you have a wider distance here, and if you make it at the posterior part of the glottis, and here is a patient in spontaneous deep inspiration, then you have the interarytenoid distance, which you also can measure in vivo under anesthesia, and this is always not a single case where this interarytenoid distance is not larger than the cricoid outlet. So we think that these people relying on radiological methods are on a wrong way. They are describing artifacts. And here, if you look at a paralyzed patient in vivo, and some of the studies were made, they paralyzed patients. The patient was intubated, then they pulled it out, make a quick MRI study, and put it back again, and they said, oh, the glottis is very narrow, which is true if the vocal cords are paralyzed. And if you, I don't know if you can see it on your screen, here is a cricothyroid membrane, which moves a little bit into the lower part of the immediate subglottis, and down there is a little entrance or exit of the cricoid ring. And well, so we could give good evidence that the people relying on methods of radiology have described artifacts. But what is this? This is the very first cricoid cartilage of an infant prepared by very good skills of the forensic anatomist at the University of Cologne. And this shows a problem. The cricoid ring, as described in a general way, is not a ring. It's something entirely else. But the outlet of the cricoid ring between the arch and the lower part of the lamina, that is a ring, like a wedding ring. But the entrance is ovally shaped. And again, you see lamina is leaning backward, and this is a funnel with an outlet which is completely circular. Okay, but to convince people, I can just mention it. We said, well, if the people don't believe us, we have to go back into anatomy, which is very difficult in Germany, maybe in entire Central Europe. Parents today don't agree to autopsies in their children, even if they died from an unknown reason. The attitude is, my child shall not be a laboratory animal, and they refuse an autopsy, and maybe 3 days later they go to the lawyer and tell you that the doctors killed their kid. But here you see what I want to try to describe is a fresh larynx, not impregnated with anything. And here is the anterior commissure of the vocal cords. Here is the interarytenoid distance if you measure it, and the cricoid outlet remains the narrowest part and is circular. but you can see how distensible, in a way you can only imagine if you see it, is up here and never impedes our intubation, but making with this autopsy specimen an MRI will say, oh, the glottic level is in a narrow spot, which is not the case. But then in the discussions, a group showed up and said, but we documented with endoscopy, you're endoscopists, we made an endoscopical study, and they used the Hopkins lens, which is very good lighting, and attached a distance holder, 5 millimeters here. They put the optical instrument at the vocal cord level, and the light level is here, 5 millimeters below the vocal cords, and they said, but we can give evidence that the entrance of the cricoid ring is ovally shaped. Well, that's correct, because they illuminate this part, namely the slanting ovally shaped part of the cricoid cartilage. If they had put this optical instrument here, they would have had a very, very secure way of showing the cricoid outlet. Just mentioning a little bit of the cricothyroid membrane, because it's very important. It faces cephalad. And in small children, making a dilatation tracheostomy is very dangerous, because you cannot see it so clearly here. The dilatation needle is pushed cephalad, and I have seen only one successful dilatation tracheostomy through the cricothyroid membrane. The other ones always ended up in the esophagus. But you can see, and most people do it, they go below the cricoid arch and the trachea, and that is safer. Okay, what I want to say, I'm so grateful to Dr. van Zundert and Dr. Puhringer. We have to visualize in a correct way. First of all, it's always good to visualize by optical instruments, but the tip of the instrument must stay in the correct place, and you must have the correct angle. Now, this is really very new in our study, which is not published yet, because this study had to undergo 7 reviewers, because half of the reviewers didn't understand what we said, because they had never seen a larynx with an optical instrument from the inside. These are the outlets of, just 2 outlets of our 30, we had 30 patients only, but 20 infants below 1 year of age. The outlet, well prepared, is circular. And what is this here? These are the vocal cords, cadaveric vocal cords. And if you paralyze the patients, we even use this expression, the paralyzed patient in vivo, if you look at the vocal cords, they are in a cadaveric position. So, is this a problem entering the larynx? You can see here is a thyroid cartilage still attached to the autopsy specimen. If you retract the vocal cords, they are flaccid, not only again in the cadaver, but also in the paralyzed patient. If you retract them or you push them aside with the tube, the space, subglottic space is open, and there is no inhibition of it. And you don't need a cuff tube to occlude the outlet of the cricoid ring. You can do it with a normal uncuffed tube. But I don't want to don't want to discuss cuffed versus uncuffed intubation, because that's a wide field. But what you see here is very, very important, because I don't know if you can see this arrow here, or is it covered? Well, there's an arrow here measuring, I can tell you, measuring the vocal cord level till the outlet of the cricoid ring. And the cuff-free distance on the microcuff tubes. We could experiment only with microcuff tubes because they are widely spread and very popular, and many papers describe the microcuff tube. But what we found out, this microcuff tube is in propaganda the best and most safe cuff-free distance from the depth marking here and the begin of the cuff. But in all patients, can you imagine, the proximal cuff was in the larynx. It was in the cricoid outlet, the circular, non-distensible cricoid outlet, and the attachment of the cuff, you can see it here, and in the propaganda it says, the cuff adds to the shaft only 0.2 millimeters. But that's not the problem. The problem is here. The cuff measures about, it's not written in this picture, but this distance of the cricoid is about 6 millimeters, and the outlet of the cuff, or the outer diameter of the folds of the cuff is about 7 millimeters. So it stayed there, and this is very new, not published yet, but we hope the article is accepted for publication in Anesthesia and Anesthesia. You can see it in 1 or 2 months. But this shows that this way of promoting microcuff tubes has ended in a dead-end road. We cannot accept this, having this in every patient. Just here, the ratios of what we measured in infants, 1.0. That's a true circle. We were a little bit angry about it because this looks like a fabricated number. In toddlers, the ratio is 1.02, which means 2% out of the one of the geometrical circle, and in children older than 3 years, it's a little bit wider. But this is not so important because the mucosa in here is so different, and if you have a fully perfused mucosa, you can push it a little bit or squeeze it a little bit without danger of damaging the cricoid, the mucosa of the cricoid outlet. Just a brief look at the normal intubation. You see, if you intubate a patient, normal intubation, there is never, ever a space behind the tube. There's always only a little bit of an open distance here, and we are waiting for a little bit bubbles of air coming out here. This is very safe. The children cannot aspirate. And it's well documented, and I took part in these experiments many years ago in Pittsburgh, Pennsylvania, where we could do it in dogs, which is not permitted anymore, and we filled it with blue dye, and if you have just 2 centimeters of PEEP, or 1 centimeter of I'm saying something wrong. No, PEEP with a positive expiratory pressure of 2 centimeters is preventing aspiration. Here you have this tube. In the close-up, you see air bubbles coming out. Well, this tube may be kind of a little bit too big, whatever. But if you endoscope a patient with a cuff tube, which is, according to the producer, same size like this, they say half a millimeter narrower internal diameter is the same like this. But the pressure on the mucosa is made by the outer diameters. And I'm so glad that Dr. Puhringer and Dr. van Zundert said, we have to visualize what we do. And if you make a video laryngoscopy, you see exactly this when you introduce a tube as recommended by the industry. You have to squeeze it with some force through the glottis and the subglottic space, but as I showed before, they all remain in the outlet of the pediatric larynx. That is really worrying, but what can we do? The message is visualize, visualize. What do we do I'm talking mainly about prematures, neonates, and infants. The Hopkins lens, it's a kind of pocket instrument, battery powered, and it's standing in a place easily accessible to the nurses. And if you have some problems, you don't even need to press a button. They are running to this place, grabbing this instrument, and you look into your larynx, what bothers you. And here you see these two patients had no stridor. They had nothing. The children could talk normally, but when we endoscope with the video laryngoscopy, we said, oh my goodness, what is this? We couldn't even intubate the patient, an old cuffed intubation. And the ENT surgeon just splitted this and the operation could go on like this. But this we could intubate, no stridor because the area is wide open. And we did the operation because it was an urgency. But of course, this patient has to be treated. But even worse, these ones, not very recent injuries, and this patient came to us because the patient had heavy pain when swallowing, but no stridor. This one had no stridor. It was intubate for something else, but video laryngoscopy showed, oh, below the vocal cords, there's a little bit, and so on. But with this instrument, in a minute, you have the diagnosis. And so we recommended for these small children to use this rigid Hopkins lens. It's glass lenses, very good pictures. But there are people around in pediatric anesthesia saying we should even intubate neonates in prematures after the 35th week of gestational age with cuffed tubes because they are so great. And these tubes don't even fit into this. Fortunately, the neonatologists refuse to use cuffed tubes, which is very good, but pediatric anesthetists do it. Now, what is this? The baby bonfils. I don't have to talk about bonfils to Dr. Zundert or Puhringer. This is so helpful if you have a difficult airway and if it's not such an airway where you need a fiber optic instrument. So it means about 100% of the, not really 100%, 90% maybe, of unexpected airway you can deal with a bonfils instrument. In this patient, from a different hospital sent to us, they said, well, there must be something wrong because we intubated. No problem going through the vocal cords, but then there was a resistance. There must be a tumor. We use a smaller tube, resistance. The smaller tube, still resistance. We stopped anesthesia, thank God, and sent it to us. And this is a normal airway, just a very pronounced cricothyroid membrane. This stops the intubation. This heals easily. And with this instrument, you could intubate safely because you see what you do. So I am at the end of my talk. I hope I'm still in my time. But I wanted to touch this article by the Cochrane Systemic Review. Cochrane, who's not familiar with this, checks scientific literature, only literature which is peer-reviewed, and where over 10 or 20 years or longer, pro and contra articles or papers are read in meetings, and what did they find? It's really shocking. All publications dealing with cuffed versus uncuffed intubation in children, are of very low quality evidence. Not low quality, very low, which means, and Cochrane explains it, if you go on with studies with very low quality evidence, you can do 100 studies, you never reach evidence. And so that's what I'm thinking and hoping. I'm an old man, and some people said, stop giving talks, your voice comes behind this tombstone kind of. I think the young people must go on and do the first high quality or normal quality study comparing cuffed and uncuffed intubation with endoscopic control, not using stridor as outcome measure. Because here I have some take-home messages. Oh, here again, you have the picture very nicely. Isn't that a scandal? We have here measurements in larynges of infants, and we can show this distance is so long that practically all these cuffs stay within the larynx. 70% of the patients we studied, the cuff was deep in the larynx, and the other one, it was just the beginning of the larynx, and as you know, every movement moves the cuff up and down, and this causes really damage. Again, I explain this. And again, this, you can measure the AID and paralyzed vocal cords. They are in a cadaveric position, and you can see the outlet is narrower than the upper part of the larynx. And this is what also Eckenhoff saw in his. He didn't make a study, but he said, when I intubate a child with a good lighting laryngoscope, then I see the outlet is smaller. And this is what I really wanted to show about this stridor business. Many people say, but if we consider stridor, then we have covered the most difficult and the most severe airway injuries, which is not true. We published this about 10 years ago. None of these children with obvious, very severe airway damage didn't have stridor at the time of endoscopy. There are many reasons why they came to our place, and because only if more than 50% of the lumen are occluded of the glottis, then stridor occurs. For instance, here you have a picture. One day after intubation, the child at that time had stridor. It disappeared, but the mother said, the child was so bad after anesthesia. Can nobody look into this? This is just swelling of the mucosa, and this will heal with no intervention. But the mother was right. Rather have a look. And again, we have to look, we have to visualize, and I hope the young generation will do a study which gives evidence what is the best approach to the pediatric airway. Many, many thanks to you. Many thanks to the music which stimulated me to this lecture. And again, thank you very much.
Thank you very much, Prof. So we still have time to for the discussion. We have several questions from the audience. First, to Professor Van Zundert, regarding the LMA insertion that you mentioned in your slides, then is there any experience that you can use the LMA for prone position, or which type of LMA that is best and would not give the condition that you just showed us? Please, Prof. You can unmute your microphone.
Yes.
Yes.
Thank you very much. Of course, by using the video laryngoscope guided insertion technique, you get experience if you do that for many years. The more bulkier the LMA, the more difficult it will be. So, yeah, that's the main problem. But with experience, you really can see all the aspects of the insertion technique. So what I want to say is the vision-guided insertion technique is based on insert, visualize, and if you see a problem, immediately solve the problem. So it is an insertion, detection of problems, correction of the problem, and then you end up in the right position. So what you can see, you can do much better.
Okay, and how about inserting LMA in the patient with prone position? Do you suggest that, or?
Well, I must say I don't have experience myself, but I have a friend in Florida who is doing it all the time for back surgery. So it is possible, and it seems not to harm the patient, but I don't have personal experience with this.
Okay, because
although I can say that once I had to intubate a patient who was stabbed in the back by a psychiatric patient. Okay, so the patient could not be moved anymore. We had to leave the patient in the prone position and anesthetize the patient. Fibroptic intubation by an experienced anesthetist in fibroptic intubation was not successful. And but I did the intubation in the prone position using the reverse handling of the laryngoscope. Okay, so what I normally do with my left hand, I was doing that with the right hand.
Okay, so still the LMA topics, Prof. Holzki, there is the questions that how do you maintain the LMA in the very small baby, the position of the LMA in the very small baby or in neonates? Do you use it for the very small baby?
Yes, you can use the LMA if you are very proficient in using it in adults. Then I think you should start getting experience in pediatrics. Now, for the very small LMAs, it is absolutely essential that you fix it. You fix it on the upper lip and on the lower lip. So that is very important. I do that all the time for my patients in adults and for pediatric patients. So fixation is absolutely important. I've seen colleagues who are not using any fixation at all. That is very tricky because the slightest pulling on the tube can dislocate an LMA immediately. Okay, and especially in the very small patients.
Yeah. Do you have any opinion, Prof? Yes, Prof. Holzki, please.
May I just make a comment on this? We have tested it in the delivery room, but one must know that the pharynx of the neonates, in particular even in the prematures, is very small. It's boat-like. And you don't have this fixation at the entrance of the esophagus. And what Dr. van Zundert said is very, very important. He gave it up because the patient was in the real position. He turned around, and you're dealing with obstetricians. They are not familiar with the airway. Just moving the child, it turned around. And if you use it, you have to fix it first, but the neonatologist in the emergency room abandoned it. They said it's too much of a hassle. It has to be fixed.
I completely agree.
Yeah. Okay. Another question for Prof. Holzki. Regarding the anatomical findings in the pediatric airway, would that be interfere with our intubation technique, or what should we consider? I mean, should we use like the G-shaped stylet or like a curved stylet, or should we not using the stylet at all? or what do you think,
Yeah,
Prof?
that's a very important question, and we have to deal with it, and I've talked about and written about it. Well, first of all, my conviction is, not only because I did it all my life, you should not intubate children under 4 years with cuff tubes. Many people use cuff tubes in surgery with tonsillectomies and so on. I have no objections against that because this is a short intervention. And if people are afraid of aspiration, which can occur, they should do it. And we never did it because we made a short tamponade around the entrance of the larynx with uncuffed tube. Never had aspiration. But it's a little bit of difficult. You have to have very good skills. There is no real contraindication against using cuff tubes for short times, in particular if they don't have this wide microcuffs with so much free folds. And in ENT surgery, normally use spiral supported tubes, and that's not the problem. But generally, for intubation, our intubation technique should stay the same as it is. However, if possible, there's video laryngoscope, there's a video laryngoscope, and we never ever have to move the tube down if there is a resistance. If you use a stylet, and again, there are airway endoscopists and working closely together with ENT surgeons. And since our ENT surgical department is 6 kilometers away, so they trained us to do simple things, secure the airway till they arrived doing a small intervention. But we have seen very, very bad damage with stylets, perforation of the cricothyroid membrane from the inside, in particular in neonates and infants. And unfortunately, I have to be in court frequently. And, you know, a normal intubation for a herniatomy ending in the death of the patient, because in that place, all patients were intubated with a styleted tube. I think that's not good, because if there is a resistance, we have to find out, we have to visualize. And again, it's not necessary. And what's in the literature, multiple exchanges of the tube damage the airway. Who does multiple exchanges of tubes in a place where they're used to intubate children if they use uncuffed tubes? It all depends on your tube selection chart. And there you will realize, and if you look into your tube selection present in your hospital, the tube selection charts are mostly based on internal diameter. If you take a 3.0 internal diameter normal tube for infants, we have checked it. There are about 8 different outer diameters, and sometimes the outer diameter is changes by 4.4 to 0.8 millimeters. That's a very great deal. So in this field, a lot has to be done. I only can say it's really not necessary to use cuff tubes in these small children. Who wants to do it has to give evidence that's not traumatic. And if we can say practically all children, the cuff is lying in the outlet of the cricoid ring, do something about it. You cannot just accept it and all I have discussions said, oh, you're with your endoscopy, crazy people, all this endoscopy. We are doing very fine with the cuff tube. It's so easy. We have to do
including the in the patients that the risk of aspiration is higher, such as for the abdominal distension and everything. So we don't use there is no need to use the cuffed endotracheal tube for those kind of patients. Okay.
Very right. You're very right, because they don't think about it. And most people don't know these old studies, which I saw with my own eyes in Pittsburgh when they studied it in animals. They put in a tube which had a leak, and then you ventilate, and then they had at that time already a Hopkins lens in the trachea, operated into the trachea, and then they gave in dye. You can see the dye sitting up there between the vocal cords. It doesn't go down because a little bit of PEEP is enough to prevent aspiration. And that's the danger of the Wijaya study, telling people behind the cuff is such a large area where air can. There is a leak in the tube, it's anterior of the tube, and if there is a tiny capillary leak around the rest of the tube, there is no way of aspiration.
Okay.
But again, we have to push and try to convince people that this first study, can you imagine? 1997, the first uncuffed study telling us that you can use cuffed tubes in neonates, and they didn't tell us how many neonates they had in their study. Could have been maybe 5 or so. Yeah. So, okay.
Okay.
Can I make a comment, please?
Yes, please.
You alluded to the fact that styleted endotracheal tubes can cause harm.
Yeah.
I think. Well, we collected at least 20 to 25 publications on traumas to the palatopharyngeal fold due to the use of styleted endotracheal tubes.
Fantastic. It's very important because we are so concentrated by the outlet and so on. And, but I know it from court cases.
Yeah.
People died.
Yes. Please let the...
It could be easy to find it in the internet, your article, isn't it?
Yeah. Please continue.
Yes.
Yeah.
So that's the reason why I'm so in favor of vision-guided insertion of endotracheal tubes, of laryngeal mask, of gastro tubes, or whatever, temperature probes. Because it's very important. What you seek, you can do better, and you can avoid the traumas. And that is so important.
Okay.
Thank you. It's very nice to have this support from you.
Thank you.
Okay. We have many pulmonologists, and like they when they want to perform bronchoscopy, then they ask us to insert the LMA. What do you think, Prof?
I'm always helpful. Well, if other specialists come and ask my help, I try to do the best I can, of course. Yeah. So, and if they want to do a bronchoscopy, I use my video laryngoscope and help them to insert the bronchoscope. We can do the same. And there was a question for the LMA gastro. The LMA gastro is a new technique where you use an LMA for gastroendoscopy procedure. Now, you can help the gastroenterologist by inserting the LMA gastro under vision-guided performance, so that the distal cuff sits into the entrance to the esophagus. If that is the case, it's very easy for the gastroenterologist to insert the scope and do the gastroscopy. And so it is a useful tool, but of course it's a very new one, and we lack a little bit of studies providing us the big data.
Okay. How often do you use LMA for your daily practice? I mean, and how do you deal with the sore throat or other complications?
Yeah, one question first, and that's how often do we use LMAs or endotracheal tubes? Worldwide, there are at least 315 general 350 million general anesthetics in a year, okay, at least for major surgery. 2/3 is an LMA and 1/3 is a tracheal tube. In my practice, I think I do it even more. I'm using, wherever I can, I'm using LMAs. And you see the indications for LMAs is increasing year after year. When Archie Brain started with it, was very reluctant to say, no, you have to use it in elective patients only, not using it in
emergency.
In emergency cases. Nowadays, you can use it in the pre-hospital setting. You can use it in the emergency case. You can use it even for obstetric cases. C-sections have been done. And I even have done a case for a cardiac surgery, whom I could not intubate. And so indications are increasing year after year. And what was the second question? What was the second question?
Yeah, the how do you manage the complications such as sore throat or other complications? Yeah.
Well, looking at the complications post-operative, when you use a vision-guided insertion technique, but a very gentle intubation technique and a very gentle insertion of the LMA, you hardly see any trauma, and you hardly see any patient complaining about sore throats anymore.
Okay.
Of course, you need to use the correct size and the correct size of a tube and the correct size of the LMA, but it should sit perfectly, and that is my aim. Maybe I'm making it difficult for myself, but I put the lat rather high.
Okay. Yes, Prof. Yes, Prof. Holzki, please.
A very important question. How long do you leave the LMAs in place? Because we had a shocking experience that we had a bilateral vocal cord paralysis. Well, it's several years ago, but made by a very experienced anesthesiologist. It was after 2 hours, and it was clear bilateral vocal cord paralysis in a normal, simple intubation. We were shocked, but fortunately, it resolved within a day. There is a little bit of literature also about this. In our case, our ENT surgeon said, probably in this case, the superior laryngeal nerve was just running subcutaneously, and you had bad luck. But there were articles saying, cuffed laryngeal mask airway, we made 8 patients, 8 hours, nothing happens. What do you think about that?
Okay, thank you for that question. I think it's a very important question. Now, how do you know that the position of your LMA was positioned correctly? Was that verified in one way or not?
At that time, not. It's a long time ago, but it was a very experienced...
that doesn't matter. That doesn't matter. If I insert it in a blind technique, my chances to be in an abnormal position are 50 to 80%.
Yes.
And I think I'm very experienced in the sense that I've been using LMAs, and one of my teachers was Archie Brain. And so he came to my hospital and he told myself how to use it. So I'm using it for many decades already. But there's a few things that I have to make remarks. First of all, LMAs have been used for many hours. There are many publications, even for days and a week or so in intensive care without problems. So I'm a little bit doubtful. If we are not sure about the position, how can you make any conclusions about the cuff pressure, about the oropharyngeal leak pressure? There is no consensus on that. And that is what we just recently, earlier this month, we published that in the Acta Anesthesiologica Scandinavica about the cuff pressures. The cuff pressure, you cannot deduct anything out of it if you do not have the perfect position. So for me, perfect position is absolutely vital. And then secondary is the size of the LMA, the brand of the LMA, the oropharyngeal leak pressure, and the cuff pressure. And you have to keep the oropharyngeal leak pressure within a certain range. I mean, it should not be too low, but it should not be too high either. And cuff pressure should be between 40 and 60 centimeters of water. And if you take all these steps, all these measures, I think you will end up with a perfectly sitting, positioned, and adequately sized LMA. You can use it for many hours, the same as for a tube.
Yes, Prof.
Yes, that's very important, very, very important. It's that time when this happened to us, we, from the very beginning, checked the LMA with a laryngoscope to see where the tip of the epiglottis was, but of course now are different times. But what, with our case, brought me to a problem which is not so well considered, and if I talk about it, says, oh, that was in your place, it doesn't happen elsewhere. This patient with the bilateral vocal cord paralysis was one case, but he got another case from the psychiatrist. And how can a psychiatrist send you a patient who had real problems from the LMA? And the psychiatrist, after 6 weeks of checking, said, this is a normal child. And the mother said, this was a normal child, but after this anesthesia, the child was totally different. It didn't swallow. And the child, imagine, had to go to the psychiatrist because of the danger of anorexia. The child didn't simply swallow. And then he said, go to some place where they look into the throat. The mother came to us and said, such and such. The doctor said they made a something LMA and there can be no problem. I said, okay, let us have a look. There were ulcers. You could see the rim of the LMA in the pharynx, because of deep ulcers, and our ENT surgeon had to really do surgery on this. And I said, but didn't you go to the anesthesiologist? No, she said, again, to the surgeon. And I said, oh no, I'll probably go to the anesthesiologist. And the anesthesiologist did not even look into the mouth. He would have seen the ulcers, and the child ended up in psychiatry. So I thought, do people really check after, if they have a patient, the LMA for days in intubation? I think they all must be checked endoscopically. It's just looking into the mouth.
Yeah.
I think
unfortunately, yeah.
Sorry.
Yes, Prof.
Okay, very, very quickly. If you look in a major textbook on airway management, like Karin Hagberg's or Joe Brimmerkohn's book, or many of these other books, you see lots of complications. But mainly, and I think 95% or even more, are due to the fact that the anesthetist did not visualize the airway correctly. So, and that is the main message. Visualize what you are doing, and we are coming all together, of course. What you see, you can do much better.
Thank you very much.
So, as the conclusion, if we can visualize, then why should we blind?
That's correct.
Right.
Okay. Thank you very much, Prof, for the very interactive discussion. I give the screen back to Krisha, please. Thank you very much.
Thank you.
Thank you, Dr. Andi for delivering such a wonderful presentation, also moderating the discussion. Thank you, Prof. Holzki. Thank you, Prof. Andre van Zundert, coming from Europe, Australia.
Okay.
Meeting virtually in Jakarta. Okay, I really wish everyone's doing well and healthy. Hopefully next year we can meet again in the future Indo-Anesthesia meeting. We can do offline meeting. And also I would like to thank as well the Advanced Medical Corpora for their support for this session. I think for this session there will be a feedback, a post, this one. Yeah, for all the attendees. If please spend some time, just scan the QR code and then it will directly transferred to the survey. It will be beneficial for the our sponsors. All right, I think it wraps up the day.
Yeah.
It wraps up this week, our week 3 of Indo-Anesthesia. Thank you, everyone. I would like to thank, we still have more than 500 participants until this afternoon.
Yeah.
Thank you very much. And thank you for all speakers. I think I've seen several speakers still in the panelists. Thank you very much. And also next week, we still have one more week. Cry. one more week, 2 more days, Saturday and Sunday, Indo Anesthesia.